Hello, my name is Ari Javdan, and I'm the project manager for the National Consortium of Telehealth Resource Centers. Welcome to today's webinar, Integrating Frontlines of Care and Specialty Services, Digital Health Tools, and Autonomous AI as the Missing Link. Today's webinar is hosted by the California Telehealth Resource Center. These webinars are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs. To provide a little bit of background on the consortium located throughout the country, there are 12 regional telehealth resource centers and 2 national, one focused on telehealth policy and the other on telehealth technology assessment. Each serve as focal points for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. A few tips before we get started. Your audio has been muted today. Please use the Q&A function of the Zoom platform to ask questions. Questions will be answered at the end of the presentation. Please only use the chat feature for communicating issues with technology or communication access issues. Please refrain using the chat to ask questions or make comments. Please also note that closed captioning is available, and that is located at the bottom of your screen. Today's webinar is also being recorded, and you will be able to access today's and past webinars on the NCTRC YouTube channel and the NCTRC website at telehealthresourcecenter.org. Please note that today, at the speaker's request, the slides will not be shared with attendees. And with that, I will pass it over to Sylvia Trujillo, Executive Director for the California Telehealth Resource Center.
Aria, thank you so much. And thank you to our global host, the National Consortium of Telehealth Resource Centers. I'm really pleased to introduce today's speaker. He is a trailblazer in the area of digital health. And I am incredibly, I think, inspired every day by the work that he has done to really lay the foundation for autonomous AI systems that are rigorous, that are evidence-based, that have pathways to both the delivery of quality care as well as to sustainable practices of clinical providers around the country. Dr. Abramoff has had a long career as a clinician at the University of Iowa. He's had joint appointments not only in the School of Medicine, but in the work around ophthalmology, visual sciences, and in more technical areas. He, however, is most well known for being the pioneer of developing a de novo authorized pathway for a diabetic retinopathy system that screens that screens for diabetic retinopathy, and can do so without having an ophthalmologist present. And this is significant when we look at disease burden across the country of chronic diseases. And given the current administration's focus on combating chronic disease, and in this case, a condition that is accompanied with diabetes, this is really kind of the groundbreaking innovation the nation is looking for in terms of leveraging AI systems and in digital health. Dr. Abramoff will talk about this journey of where the challenges are, where the opportunities are, and I hope you have your questions ready to go. We'll have a conversation at the end of this. And with that, I'd like to turn it over to Dr. Abramoff. And so we're going to switch gears because he's going to be driving his slide deck. So we're going to go ahead and have Aria hand it over to Dr. Abramoff, and he's going to load the system. And it'll take just 1 second before he starts so that you could see his slides.
Just confirming that you'll see my slides now, correct?
Correct.
Okay, awesome. Well, thanks for the praise. And there was a hint that I have a long career, and you can see from the color of my hair that it has been a long career already. Well, thank you. I'll be talking about what Sylvia was mentioning. I realize now that I'm not going to talk much about the problem we are solving here, which is the blindness and visual loss from diabetes as a complication of this terrible disease. And what should be done about this is having patients with diabetes get a diabetic eye exam, because that's been shown extensively to prevent blindness and visual loss. But the challenge has always been getting these people to these eye exams. So I will not dwell on that too much. I actually didn't put any slides about that problem. I will be talking more about where we are, why we are where we are with AI, and especially integrating specialty care and front lines of care, primary care, primarily. Trying to advance my slide here. Okay, I have conflicts of interest that Sylvia already mentioned. And what was really nice a little while ago was that Medscape asked the chief data scientist, the chief data expert at Stanford, what he thought was the best AI healthcare tool, and he came up with what I happened to develop as the first one, which is, great praise and just maybe a little bit of recognition for what has been more than 2 decades of work. And so, like I said, it solved this problem of getting diabetic eye exams to patients with diabetes. Only 85 or 15% of people with diabetes get these eye exams. 85% do not get a regular eye exam. And so what can you do about it? We have had standard telemedicine, which is putting cameras into primary care offices and then having ophthalmologists and other eye care providers read them remotely, but that hasn't moved the needle much. And so this solution is slightly different. You could still say it falls under telemedicine, but now the diagnosis is made at the point of care in primary care by a computer. So there's no human involved in reading or evaluating the images, diagnosing or recommending what should happen with the patients based on what is diagnosed. So it was FDA de novo authorized, as it's called. You can call it approval in 2018. And like Sylvia was saying, it's fully autonomous. And what it means is that a diagnosis by itself, it also has a consequence for medical liability, because the liability for performance of this AI is not with the provider, it's with the company, it's with the creator of the AI, because they are the experts of what they built. And the doctor is just using it and should not be held liable for a misdiagnosis or lower than appropriate performance as met by the FDA trial. There's proven to be no racial ethnic bias. That we did a lot of work on it over many years, even before FDA clearance. It is more accurate than any retina specialist. I'm a retina specialist, a vitreoretinal surgeon myself. I still practice, and it's way more accurate than me, and I'm pretty experienced. It is billable. It's both reimbursable under what is called a CPT code 92229, as well as for MIPS and HEDIS care gap closure. So a lot of work went into that after the FDA authorization. Will go into that. What you see in the top right should be an animation. It is not. This is where we were maybe last year in terms of patients having access through this AI. What you see on the bottom right is what it looks like in clinical practice, in a clinical environment in a primary care clinic in New Orleans. And you also see that we have them on vans, including in Michigan, where the van is mounted in the camera is mounted in the van, and the whole system works out of this minivan. I want to show you a video of a patient, because only rarely do you see patients actually interacting with an AI.
So I'm really thrilled to see it happening. Illuminetics core exam was very non-intrusive. And you just walk into an office and sit down and put your chin in the breast, and they push a few buttons and get the results.
And you see how
technology,
quickly that went, right? And that's sort of key. It's not like, very complicated computer systems with bells and whistles and looking very scary. It's totally integrated into workflow. And essentially, the patients don't know they're being diagnosed by an AI. It's just that because we videotaped her and we did this interview with her, that she realized she was being examined by an AI, not by a doctor. So I want to relate this to the subject or the title of this presentation, which is integrating specialty care with primary care, especially for federally qualified health centers. And what this means is that if you have the normal practice where patients with diabetes come in for their diabetes management, typically every 6 months, sometimes every 3 months, patient intake happens, vitals are taken, then they will meet the physician, and they will discuss weight, maybe the script for metformin or insulin or whatever. And then every year, supposedly, the provider tells the patient, you need to see an eye care provider for your diabetic eye exam. And like I mentioned, that only happens in about 15% of cases that the patient actually show up in that specialist, in that ophthalmologist or optometrist office. 85% do not. And they are the ones that go blind. But again, if they have the diabetic eye exam, it's early enough before there are symptoms to catch the disease, be able to treat it, and they won't have visual loss and they will not lose vision. So again, there's lots of evidence of that, but the key is that they need to have that eye exam. And here, as you can see, it's integrated, into that primary care clinic workflow, where essentially by the time the patient is linked for the provider, the result, the diagnosis, which happens in seconds, is already available, and they can therefore discuss when it's normal, just come back for your regular encounter, and we'll do this again in a year, or it's abnormal, and we're making a referral. And in many health systems, the referral is made automatically if the AI is positive. So that's the integration that you can see now happening through AI, where there's a almost direct link between specialty care and primary care. Everyone knows why they're doing what they're doing. And so, on the one hand, it's exciting and a success. This was a recent paper in New England Journal where they looked at claims data and see, what AI was being used, because FDA has cleared more than 900 different AI systems all over medicine and healthcare, but it is not the same as getting actual patient utilization, and claims data help you with that. And what you can see here is a graph from that paper. The blue one is a cardiac one. The company is called HeartFlow. It analyzes CTs for coronary artery disease and helps a cardiologist make better decisions. So it's not an autonomous AI. It's an assistive AI, meaning it helps the clinician. The second one, the orange one, and the fastest growing one in terms of patient utilization, is this diabetic retinopathy autonomous AI that I helped create. All the other AIs that you hear a lot about are actually not seeing much utilization. And it's interesting to see from that curve also what it took, because 2018 FDA quote approval unquote, CPT code 9229, national reimbursement, and only with that did it really start to take off, where there's now over 100,000 patients per year. But compared to the 35 million people with diabetes in the US, that is less than 2% of all US patients with diabetes who need this exam. So we're absolutely not there, even though everyone is talking about this and everything had been done, meaning all the right things in terms of reimbursement, coding, FDA, payers supporting it, clinicians supporting it, including the American Academy of Ophthalmology, the American Medical Association, regulators like FDA supporting it, patient organizations like American Diabetes Association supporting it. 6 years later, only 2%, right? So meaning, and with all the evidence we have in terms of randomized controlled trials, we'll talk about that it is better for patients. So I want to say a little bit about this long journey of getting from, on the left, an algorithm, an AI, and this slide was made a few years ago, and not as many people were familiar with the term AI or what it might imply. Now, most people are actually using it day to day. But anyway, if you have a diagnostic AI algorithm and you think it works, that doesn't mean you can actually get it all the way to the right to show patient benefit and actually get it to the patients who so desperately need it. And in our case, it took creating an ethical framework for AI, which was a little bit of a surprise they had to do that, but didn't exist at the time. Now it does. There's several of them. And it really helps regulate AI. And so part of what we did was use the ethical framework to create recommendations for regulations together with the FDA. And that work continues to this day. And that ultimately, things like liability. What do you compare the AI to? Do you compare it to a doctor or to clinical outcome or something else? All these things had to be developed, had never been done before. And that ultimately led to, in 2018, the FDA clearance. I already mentioned liability was a big concern. Some companies rather do not want this liability, but I think it's A, unseemly, and B, it will not work. Meaning, if you're a primary care provider and you're using a system where you're not comfortable doing this eye exam yourself, and are now still held liable if that algorithm makes an error, I would certainly not be using it. So I think one of the key issues was solving this liability. Very many concerns with bias, inappropriate bias, and how to analyze that, how to prove that you do or do not have it. So we did a lot of work together with FDA, published papers and frameworks on that. Very important for primary care as being part of a standard of care, and work closely with the American Diabetes Association to make it part of the standard of medical care in diabetes since 2019. And it was also very helpful for payers to be more comfortable with paying for this, because they're concerned about overutilization. Are we paying for the right thing? Are we opening the floodgates for many types of AI that actually do not benefit patients? How can we separate those? So lots of discussion continues to this day. Then very important, any provider, and especially health system, if you say, well, if this really innovative tool or technique or AI, and it's going to make your patients much better, the question always will come down to, can I get reimbursed for it? And so that was a key thing to solve, because no one had solved how do you pay for AI rather than RVUs for a provider, for a human, because there's no human work being performed, at least not on the diagnostic side. And so we had to create a framework for that. It's still ongoing work, but at least there is national reimbursement at a actually interesting rate. We'll go into that a little bit. CPT code 9229. And then most important, ultimately getting it to patients, you saw that, but also creating the outcome evidence, meaning creating and doing the randomized control trials that hopefully, and they do, show better outcomes, reduced health disparities, increased physician effectivity, etc. And so if you step back a little bit, I think people ask me, why did it happen? Well, you saw the long path, right? But also I think it's putting patient outcome central. And that is not always the case, to your surprise maybe, but you see too many square pegs for round holes, siloed technology, where it's really the technology that starts it. I call it glamour AI, which is essentially AI that's really cool from a technical perspective, and people love to build it, but it doesn't really solve a patient outcome problem. Right? And it's a solution looking for a clinical problem. I think the better way is to start from patient outcome. What can any system, including AI, maybe it shouldn't be AI, do to improve the outcome for these patients or for a population? Which role, if any, can AI play in that? And then start building that. And that's how you get round pegs for round holes. And I like this picture very much because I'm from Iowa, and we have all these silos for grain here. And so people often say you shouldn't work in a silo, and it's absolutely true. Do not work in a silo if you're developing AI that you actually want to benefit patients, because it will not lead to rainbows and little ponies with pink glasses on. You need to integrate it in the wider healthcare system, as well as interact with the stakeholders. And I like this picture because sometimes I'm accused of making it overly complicated, but the healthcare is a very, very complicated system. There's so many involved, including patients, populations, and their organizations, physicians and other providers like AAO and AMA, AI creators like myself, bioethicists, regulators like FDA, value-based care organizations, including NCQA that you may have heard about, United States Preventive Services Task Force, payers, crucial role, CMS, state Medicaid, and commercial payers, investors who are ultimately funding many of these technology initiatives, and then ultimately also Congress and even state governments are deeply involved in AI, regulating AI, paying for AI, etc. And this could not have happened with the support of these organizations on the right, NHMA, NMA, and AMA. And so about this ethics, that was also an important component. And you see some companies struggling a little bit because they essentially have ethical experts looking from the outside in on the technology that's being developed. And then you have these AI ethics teams, and you see some publicity around these here where, quite publicly people started disagreeing, but that's not the same at all as having ethics as sort of the core of what you do on the technical side. And so what instead we did was create this ethical framework based on very simple ethical principles that maybe you haven't heard about, but it's benefit to the patient, autonomy of the patient, and justice or equity. are the core across most cultures and across thousands of years. So they're not new. And if you build your evaluation of AI, where it should fit, what it should do, what it should not do, what sensitivity and specificity should it have, I think that's key. And part of that is placing patient outcome central. And what may surprise you is that not always in biomedical ethics is the patient outcome central, and it's often very much about the patient-physician relationship. But then, of course, there's no place for autonomous AI because there's no physician there. So how does it relate to an AI in a patient? Well, it's about patient outcome. Similarly, by the way, for value-based care, which also does not fit into bioethical framework where you look at patient physicians, because here the payer is having a direct influence on what the patient care gets. And so the other insight was that we wanted to quantify how much a bioethical principle is being met. So we did a number of papers. I'm not going to show the deeper underlying structure of the bioethical framework, but suffice it to say that we were able to measure how much it meets patient benefit, various metrics, how much it meets autonomy of the patient, how much it meets justice. And then you have to find a balance between these three. Maybe you want more patient benefit and less justice, or maybe you want more justice and less patient benefit, but you will have to find a balance. And that is, of course, not something any technologist or any tech company can answer. That is society. Together, we need to answer this, but at least you can measure it. And that's, I think, what these publications are about how to measure how much you're meeting each of these ethical principles, including, for example, for reimbursement for AI. And you would not think that ethics would be the core for a framework for reimbursing AI or paying or charging for AI, but it is actually. I will skip this because we have only a few minutes left. And so I want to skip to outcomes. So I think part of what it should be about is that it improves outcomes. If you create glamour AI that doesn't move the needle, why are we bothering, right? Why are we trying to get it to patients? Why are we trying to get it regulated? Why are we trying to get it reimbursed? So it's key. And currently that's not part of FDA requirements for medical devices, at least not for category 1 and category 2. To do outcome research. So we did it both before and after FDA authorization. And there's now numerous papers from randomized controlled trials and other studies showing better outcomes on the patient, better outcomes for the clinician, and better outcomes for populations. I think a really cool one, and that had never been done, was productivity. And it's a key item for me. Lower healthcare productivity leads to higher prices, all else being equal, lower access, lower availability, health disparities. And for me, increasing productivity in healthcare is key. And I was hoping that this autonomous AI will do that, because an assistive AI, ultimately, you still need a clinician, right? You don't solve this problem. But if you have an AI that's actually doing what otherwise the doctor would be doing, you can scale the doctor. And if you have 1,000 AIs, you do 1,000 times as much as one doctor. And so, but that you still need to prove that. So what we were able to do together with Orbis, the Flying Eye Hospital, that's philanthropic organizations that puts high quality eye care into low income and middle income countries. And together we did a randomized controlled trial comparing, in this case, patients seen and diagnosed by AI and without AI, and clinics with and without AI, and see how much more clinicians, specialists, how much more productive they became. And it was like a 40% gain, which may sound like okay, but it's actually what our entire economy has gained over the last 50 years. So it's a lot. And I'm very excited about this result. I will not skip the details. And so with all this evidence, we were able to get into the standard of care published in Diabetes Care a while ago. And what was really interesting was the deep discussions within CMS about reimbursing this AI, ultimately ending up with about $55 per patient, $80 for a blended rate. Medicaid is a little bit more like $30. That was key for adoption. But again, even with this, it's still only 2% today. So I've been very much working on policy and legislation and other aspects of how can we scale AI where we have shown a benefit, right? And there's other AIs which also have benefit. But if we cannot solve this, we can think all we want about using technology to improve patient outcomes, population outcomes. But if we cannot get this pretty obvious one to benefit 80% of patients, then we have a bigger problem. And so how do we scale this faster? And there's a lot of discussion we can have, and I would love to have the discussion. But that's really the core of my more recent work. You see a recent paper in the New England Journal about this. So back to the path. It was a long road. It is not like other AI companies now have to do this same very long road because we now know what to do, right? A, we know it can be done, and B, we sort of know the different steps and the different stakeholders. And you can ignore that, but then at your own risk, I would say. Or you can just work with them, and then definitely it can go much faster because people are just getting more familiar with AI as well, both on the patient as the provider side. This is about, I can come back to this slide, maybe during the discussion, but I will stop here because I'm really looking forward to a good discussion. And I've spent like 25 minutes. Okay. Try to talk slow, but apparently I wasn't slow enough.
No, you did great. Or yes, you did great. Actually, why don't we pull that slide back up? I think it's a good one. It lays out the journey that you took to get to a place where there's a pathway, the pathway one that sort of all
This
the
one,
steps.
you like this one? Sorry,
One
I want
more.
to.
It's that one. Perfect. 31.
Oh, okay. Yeah.
I think this is really helpful for the folks in the audience. And I'm gonna start with a really straightforward question, Dr. Abramoff, and then move to probably a little more spicy conversation around some of the issues that are rapidly emerging with generative AI. So I'm gonna pick your brain about that as well. So you talked about the adoption rates remain pretty low here, even though there's pretty, I would say, substantial evidence to support this as a model to meet an area of significant disease burden and cost in the nation. So, if you could distill it down, what are the main impediments to adoption? What's the rate limiting factor here?
It evolved over time. First, it was the bias: is this safe? Many health systems were not familiar with AI. I remember the day FDA cleared this, I got a call from one of the biggest pharmacy chains in the country who had 11,000-minute clinics. And we talked for an hour, and he said, I want this in all 11,000-minute clinics. And I thought, wow, that's great on the first day because we had no customers. And at the end, he said, well, what about reimbursement? And of course, there was nothing. There was no answer because CMS didn't want to talk until FDA authorization. So I thought all the financial aspects and solving that like you do for regular things that doctors do and providers do would be sufficient. And that's, I think, was not enough because it's so new. And what you see, especially in primary care and federal qualified health centers, is that they have almost no reserve, both in manpower, in budget, in time. And so if you come in with something that is upfront effort and a little bit of risk and new, and then you say, well, but at the end you will get extra financial impact and it will be better for your patients and easier. It's a risk to take, and they can also say, well, I will wait a little bit, right? I think part of it is this upfront that you need to invest before you see the results, and then you can come with evidence that other clinics do well, but that slows it down. And so part of the work, and maybe we can get into later what I'm trying to solve, but yeah, so that's I think right now the opaqueness of reimbursement, especially of value-based care. Let's talk about MIPS and HEDIS, where yes, there's a monetary reward for the payer, but not for the provider directly if they meet more quality measures. But it's indirect, right? You need to meet the diabetic eye exam, but you also need to meet something on the orthopedic side. And only then do you see a monetary return. That's very hard to figure out. Okay, if I do this investment per patient of $40, $50, am I getting back $300 or $3? or something in between. And if you don't know that, you can actually lose money the first year. And that's too risky for these clinics who are really, very much at the margin of what is possible. They do awesome work and they hardly meet their budget, right? So I'll stop there.
Yeah, so I think when I worked at the AMA, this is true for all digital health adoption, and AI is not unique in the type of modality, right? So, looking at telehealth, remote monitoring, AI, all of these are considered disruptive. They all require change management. They all require an upfront investment in terms of workflow, training staff. And so you also, I think, add on a layer here where the wait and see attitude is not simply around all of those factors, but also there's a lot going on in the discussions around AI. And so that brings me to this next question. There's so much discussion out there in the ether around AI, and people are often talking about very different AI systems and methods. So I wanted to bring your attention to these recent studies performed by Stanford, Harvard, and UVA around generative AI models. The one that was tested by Stanford is called AIME, AIME. And UVA used just ChatGPT 4. And their studies found that they could outperform clinicians in certain diagnostic tasks. Now, this is very different than your system. So, my first question is, how is what they were doing in research around a generative AI system different from what you developed and what others have developed? Because you're not the only autonomous diabetic retinopathy screening platform. But how are these different? And then I want to ask you about your thoughts around what the regulatory environment for what these researchers have been basically sharing with folks and saying, like, this is an example of how rural communities can have better access to specialty care. When the model you followed follows all the steps you're required to follow for any, whether it's telehealth or remote monitoring or x-rays, that you follow this path, but the adoption is low. So what is your first reaction when you hear about these types of claims by researchers and thinking about the pathway to adoption?
Yeah, no, great question. And actually, and I sent you the paper yesterday. We have one that is coming out soon, doing a similar thing where we measure the performance. It's important to realize that the most interesting systems are, I think, where it's emergent. And what I mean by that is that, like ChatGPT or Grok or whatever, they are built not with a specific purpose in mind. And the fact that they perform at a certain level on a very specific thing, like a diabetic eye exam, is emergent. It was not built in. It was never trained for that. Unlike the system I built, which was specifically trained to do this specific task. That has several implications. One is that we build it and that's different from, there's two other companies doing this. They follow what we did. We build it very deliberately around how a clinician makes these diagnoses, meaning they look for certain biomarkers or lesions in the retina and make the decisions based on these biomarkers. So we know what the AI does at very fine-grained detail. These systems, like ChatGPT, no one knows and understands why they come to the conclusions they do. So that used to be a big thing, explainability or transparency from the ground up, right? Where you can validate each component of your AI. Now that people are more comfortable with AI, that's becoming less important. And I understand that makes total sense. I think the other aspect is that these systems can only be as good as their training data, right? And the training data is typically, there's known data sets that are out there which part of which I helped create with images and diagnoses from the retina. And that's what this emergent behavior is based on. They have access to data on the internet, and they make these associations in more or less sophisticated ways, depending on how the AI was trained and built, and continues to develop. And so you need to be asking these very specific prompts in a very specific way, so that essentially you need to build a system around it to make sure that the input and output matches, that you can do something with it, right? So if you want to use this in a clinical workflow, so now it starts to be where you have this system which changes, right? As every day, ChatGPT and Grok are different. There's a little bit of an issue there, because if you validate it today and say, hey, this is safe, there's no bias, it may be different tomorrow, but these changes are small, and we're starting to see how they slowly drift, so that is manageable. And so it's starting to be interesting, and I think the paper I wrote is really about, I think, getting to human performance is achievable. It's not there yet, if you look at it very objectively, and I'll get back to that. I think it's harder to have superhuman performance like our system does, because this was not trained by comparing it to clinicians like me. It was trained against clinical outcome, predicting clinical outcome, essentially saying, oh, we see this in the retina today, therefore you will need this or that, or otherwise you have this or that complication a year, 3 years from now. And that's why we can say it's better than a human, because humans are actually not perfect against such an outcome standard. So if I look at the patient, I'm not as good as predicting outcome, predicting need for treatment as the AI is. And that's why I'm able to say that, because we validated the AI against outcome, right? And so if you, and we sort of started doing that in the paper that's coming out in the study. We did a diabetic eye exam and started comparing that. And then you see it's still subpar. But what we measured was below humans, but it's getting there. Of course, you cannot train it for that. It's the whole point, right? It's emergent behavior. If you start training it, now you're a medical device. But what is the avenue, I hope, maybe, is you have this system, it's there, and now it gets interesting, because these systems do meet other criteria for what providers meet, which is MCAT, USMLE, empathy. Many tests that you can do on clinicians also qualify things like Grok and ChatGPT in terms of taking a history or examining the patient, etc. So one path is, rather than a medical device pathway, is the medical licensing pathway to state medical boards, where you say, well, here's I call it off-the-shelf AI, meaning you don't change it, right? You build something around it to make sure that the input and output is clear. And then you say, well, it can meet all these, so to say, soft requirements for what physicians and other providers do. And just like physician assistants, essentially create a license where you test it on specific tasks, which is what humans never get, right? I, as a clinician, I'm never evaluated on my sensitivity or specificity for any disease or any outcome. It's because I did my boards, my CME, my other licensing requirements. No one ever checked it. No medical board ever checks that. And so you could see a path where the AI is checked on very specific things that you want to license for, and in the background still have these skills that physicians have, and therefore say, well, we'll license it. I'm not sure that's where we want to go, but it may go there, because again, we need to get patients to access these systems, because we know, well, at least we have shown for our system that it's better for outcome. Of course, you need to show this for these ChatGPT-like systems also. So, long answer. It's a very exciting debate, I think, and part of it is, what do we want here? Do we care about patient outcome and access? Do we care about superhuman performance and making it actually better, rather than just substituting what you have now, which is sort of the physician assistant model? Very interesting questions, which I, by myself, do not know the answer to. I know where I want to go, but not where society wants to go.
So I want to take it way back for our listeners. I just want sort of a functionality and method clarification between this system that you ran through the FDA, right? And through quality measures, but really specifically the FDA, Your model uses the diabetic retinopathy model uses screening for diabetic retinopathy, a locked machine learning model, meaning it had its learner unlocked, the learner learned, you came to a model, you stopped the learner, and then you sent it to the FDA to be evaluated, correct?
Well, yeah, well, you have not the FDA, but someone else does the evaluation, the validation, the trials. Yes, but yes, essentially yes.
Yes. So they evaluate, you had to submit that evidence to the FDA that this got evaluated, right? So that this specific model, and it's not going to change. It's not going to modify itself in the middle of an exam or immediately after exam, after
Correct.
it's
So that's key
data.
that
So
it
that's
remains.
so I want to make sure that the distinction is
Oh,
made
okay, right.
between what you have done and what we've been talking about here versus a generative AI system like a ChatGPT or a Grok that is unlocked and in fact changes, as you said, like every time you query it. And it could be consuming data from a lot of different sources and and it may be valid today, but it may not be valid tomorrow, right?
Because yeah, so most of the AI itself that you see here on the left is almost a commodity. I mean, people can buy it easily. It's how you develop it and build it and validate every specific component that it will not do funny stuff in edge cases, which is not the case, of course, with ChatGPT because it's trained. It can be different for you and me at the same time. And so if you validate it, you don't really know how good it is, how safe it is, how biased it is, etc. So to do that would take a giant effort. You have something called software quality systems or ISO certification, which essentially is 90% of developing these algorithms for medical devices is documentation and testing, and only 10% is actual building. And that to do that would make ChatGPT probably impossible to build today. And so you can say, well, we require that for medical devices and not for these systems, which is, I think the FDA medical device pathway is going to be very, very difficult for these systems because you would have to carve out something, lock it, and essentially you're saying, well, I cannot train it anymore because not on specific data, because otherwise you're just building a medical device AI that we know how to do, right? If the innovation is that it is generative and you do not build it for a specific purpose, yeah, you can make it into something that is for a specific purpose, but then you lose all the advantages that otherwise are there.
So, okay, and I think that's a really important distinction for two reasons for our audience to understand. The first is that the existing deployments of an autonomous AI system in healthcare that enjoys the imprimatur of the FDA has gone through these very rigorous processes. It's been validated and it has been built for a specific purpose and it performs as expected for that specific purpose. And so when people talk about AI systems, we don't want them to confuse generative AI models versus those models that are currently going through the FDA. And I will get to, and I want to sort of pull out a little bit more what you see is likely going to happen for generative AI systems that are built for general purpose, but that we're starting to see over time increasingly have high levels of accuracy, like that are diagnostic and also have other attributes of what we'd call like bedside manner. So I'll ask you about that in a second, but I want to make sure everybody understands there's two different pathways. There's two different, theoretically two different pathways, but there's already autonomous AI systems that have gone through existing models. And to your point, it begs the question, why is there such a low adoption rate for those that have gone through all these trusted sources for purposes of adoption. And I think as a telehealth resource center, what I have observed is that it's not the technology that's the rate limiting factor to adoption. The rate limiting factor is always people and resources, right? And so you've nailed it, Dr. Abramoff, that if you don't have the resources to implement the technology, and if you don't have the people to do it, then you have a great technology, but no scale. So then the next question is these generative AI systems are already enjoying really significant uptake in the general public. And so there's nothing necessarily foreign about these because people are using it for all kinds of questions in their life. So these generative AI systems, you talked about a possible pathway for them that looks like going through a licensure process. And I would like to understand, are these really the solutions for chronic disease? Like, do you envision that these general purpose generative AI systems are those going to be where we address the highest disease burden conditions in our country, or are we still going to need this more established process? Because the administration is very focused on chronic disease. We have a crisis of obesity, cardiovascular disease, and diabetes. Where do these two different AI models fit in that discussion as possible solutions?
Yeah. So again, I want to make sure I favor the path of superhuman performance and better because I think it will, well, I know it leads to better outcomes for patients, and that's ultimately what it should be about. But two things I think we need to change, and we can talk about pre-authorization by AI and how that would fit into primary care. But that's not what you want to talk about. And the other one is how can we accelerate the regulatory process, partially by improving how we design clinical trials, and I'm not going into that either. Partially it is by FDA being, and we have created something called the collaborative community, which is together with FDA to create standards outside of FDA that the FDA then applies for innovation, including AI. And that needs to accelerate because we know clinicians and scientists and ethicists know what to do. It's how do you get it into a regulator that is the big problem. There's a lot of science out there about how to regulate AI, how to validate it, what it should be compared against, etc., and why certain things are better or worse. Not yes or no. It's more, what do you choose? The point being that part of this is that the regulatory process is way too slow. And so bringing attention to, well, maybe we should think about medical licensing pathways also to make sure the FDA and Congress sees that we need to change something. So that's important. But I think we have an opportunity right now to create systems that are actually better. And why then go with something that is actually, performing necessarily less than what we found anyway. If you measure it accurately, it is still performing less than human experts. So why go that route? Because the problem with adoption will be the same, right? Either it's a totally generative AI that's off the shelf, but then you don't know what it does at all. And as soon as you go building protections around it, now you're getting a medical device arena, liability. Does OpenAI want to be held liable for a class action lawsuit where it missed 5 diagnoses and potentially 10,000 more? It will bankrupt the company immediately, right? So they don't want that. So who's going to take that on? And so that is unanswered. It's, I think, going to be an interesting discussion. But that's separate. So this is the regulatory aspect, which is separate from the reimbursement aspect, which is probably as important, like you mentioned in the beginning.
So what do you see happening in the next 5 years and 10 years in this space? And I'd like your views in terms of the most optimistic and then the most conservative.
The most optimistic is that we get our act together, regulators. We create two things, an actual AI approval. So for your understanding, FDA approves pharma the drugs, right? You do randomized controlled trials, you show better outcomes in the group that got a new drug that gets approved and almost automatically reimbursed by most payers, including CMS. That's not the case for devices. You have a safety evaluation. So for category 1 and 2, essentially FDA signs off on safety, not on outcome. And so there's various mechanisms we have been discussing with everyone about, can we include outcome data and can we make agreements with payers that if we show these outcome data, they will reimburse it out of the gate, so you don't have this enormous delay between FDA clearance and reimbursement, which can be years and years and years. I've seen so many companies die after FDA approval because they couldn't get the reimbursement working. Either because it didn't work, but many times because it worked and it just weren't able to organize the data maybe the right way or getting it across. So I think if we solve that, and if we solve the transparency of the reimbursement system, so it actually a provider, not a very sophisticated Wall Street financial wizard, but a simple provider, administrator, and FQHC can see, if I invest this much, I will get this return, or I actually get money up front and now I can do it and I can take the risk. And the financial impact is positive, so I will do it, or the financial impact is negative and I'm not doing it. If we make that very transparent very quickly, we'll see hundreds of these in the next 5 years. There are so many AIs in all specialties, cardiovascular, dermatology, neurology. They're all, investors are waiting, the companies are waiting, and as soon as this is solved, boom, right? So I'm optimist, otherwise I wouldn't be doing this. So that's what I expect. But there's a few little things we need to change here and working hard on that. Of course, the most negative one is where we don't get our act together. People will start escaping, will be liability issues with ChatGPT, there will be class action lawsuits. The biggest disappears, people will do it, illegally. You will probably have, be importing ChatGPT from somewhere else, right? And you see that sort of stuff happening, and that would be not good for patient outcomes and not good for, the sustainability of the healthcare system overall. So yeah, you can be very pessimistic. I don't expect it will happen.
So we now have big players. So Stanford worked with AI. Stanford and Google worked together on this AIME, and it's specifically intended to be medical. So it does sort of beg the question of whether or not what they're building is a medical device or not, right? Because it's curated specifically to address diagnostic challenges. And so I will be curious. We're going to be speaking to the researchers next week. We have a summit with some panelists, and then Dr. Abramoff will be part of a boot camp that many of the TRCs are co-hosting, launching at the end of the month. So this conversation will continue, including with some of the very folks working like yourself, not just in the existing regulatory FDA pathway, but as we look out towards the future to generative AI models that are general purpose and others that are being built specifically for medical diagnostics. We're getting close to time, and I want to give you an opportunity to highlight what were the most important lessons learned. You were the first person to with your team to trailblaze this pathway for autonomous AI systems. What are the most important lessons for not necessarily innovators, really for clinicians? What's important for them to know about autonomous AI systems in healthcare? And I'll just leave it at that. What's the takeaway message you want to leave them with?
I think it's important to focus what is best for the patient, and consider what role, if any, AI, any technology can play in that, and work your way back from that, instead of looking at, well, I'm used to doing this and that, A and B with the patient, and I'm just looking for something to do that with a machine. I think it's key. What is best for the patient? How do you make that the most optimal way and choose, whatever technologies you're interested in based on that? I think that helps make the decisions. For example, still in some healthcare systems, we go in and we say, hey, there's this diabetic eye exam that you can now do with a computer. And we know that's necessary. It's not happening, right? Still, because we need 80% penetration, but right now, the vast majority of people with diabetes are not getting these eye exams, so they're not getting them. And some of my colleagues then push back and say, well, but it doesn't diagnose glaucoma, it doesn't diagnose this or that. And the interesting thing is that it was never designed for that, but more importantly, that there's already decisions being made by payers that they do not want to pay for screening for those diseases because it is not cost effective, et cetera. We can discuss whether that's right or wrong, but the point is, here you're doing something that is actually considered and lots of evidence that's beneficial. But instead of then saying, well, we need to do that because it's better for the patient, if it then becomes, well, the process doesn't include all the things that traditionally were part of the eye exam, even though it doesn't affect patient outcome, that is sort of what I mean by focusing on patient outcome and trying to fit, well, not trying to fit, choosing the technologies that do best on that.
So I'm going to close out. I said that was going to be the end. I want to
Oh.
hand it. I want Aria to come back on because we're going to wrap.
Okay,
Before
I will
we
stop
do,
sharing, right?
yeah, but before we do, I want to ask you one key point, and this was really critical in the conversations we had years ago when I was at the American Medical Association. Um, Briefly, what are your views if you have an autonomous AI system? Who's has the liability for a wrong decision?
Oh, sorry, I said it. So the liability for the performance of the AI is with the creator of the AI, in other words, the company. Why is that? Because I cannot understand how I, as a provider, would use an AI that makes me liable for an error that some programmer has made. But why would I do that? And so because they're the experts, I'm not. That's the whole point. I ask them to do it for me, then they should be all the liability. Has that been litigated? No. It will be, but it hasn't been. But by being out in front of it, I hope that juries who are going to decide on this, that they see, well, this is key if we want to do this right. And I think, in other autonomous AIs, in other non-medicine fields, it's being held back because this discussion about liability not being solved. I think it's key.
Yeah, so I want to pull it back to telehealth just in a
Oh,
nutshell.
yeah.
So this is different than telehealth and RPM and e-consult, where the liability remains with the clinician, and this is a difference in digital health. And as providers and patients, we need to be clear that our expectations for the innovators around these AI systems, particularly autonomous ones, that we ensure liability and accountability lies with the developers, and that can increase trust and appropriately aligns incentives. I want to thank you, Dr. Abramoff. You've been terrific. We appreciate all that you've done. Aria, you're the best. I'm going to hand it off to you. Take it away.
Thanks so much.
Sophia. Just a reminder that our next webinar is going to be held on June 12th, and that will be hosted by the Southwest Telehealth Resource Center on the future of telemedicine and digital health to catalyze care delivery. Registration information is available on the consortium events page. And then lastly, we do ask that you take a few short minutes to complete the survey that will pop up at the conclusion of this webinar, as your feedback is very valuable to us. Thank you again to the California Telehealth Resource Center for hosting today's webinar and to Dr. Abramoff for his presentation. Have a great day, everyone.
Okay, thanks so much.